We looked at the Hep C life cycle and mechanism of action of antiviral agents. We looked at AASLD recommendations for treatment of Hep C, and we evaluated drug-drug interactions. Now the next learning objective is given an Hep C patient, design an individualized monitoring plan. There are 3 phases to Hep C monitoring. There are things that we need to do prior to starting antiviral therapy, and then there are things that we need to do during antiviral therapy, and then we need to do things after completion of therapy. Before we actually start antiviral therapy, it's important for us to evaluate the hepatitis C genotype and subtype. So this is after someone gets diagnosed with Hep C, we need to determine the genotype and subtype because that determines which regimens to use as long as how long to treat the patient. Quantification of the Hep C viral load also helps in that process. It's important to evaluate the patient's hepatic function as well as the patient's renal function because these two will also determine how to select appropriate regimens as well as how to dose appropriately. We also need to monitor complete blood count as well as INR, especially in patients with cirrhosis. As you know, as the patient's cirrhosis progresses, these numbers will be very important. It's also important to screen the patients for hepatitis B virus before starting treatment for hepatitis C. And for screening, we looked at the Hep B surface antigen as well as anti-Hep B core antibody as well as total anti-Hep B surface antibodies. And that's because there have been case reports of reactivation of Hep B once a patient started treatment of hepatitis C, including fatal flares. In fact, the FDA has actually put a black box warning for all agents used for hepatitis C, stating that Hep B virus reactivation has been reported in some cases resulting in fulminant hepatitis, hepatic failure, and death. So it's important to screen the patient for hepatitis B, and if they are positive, they should just receive treatment for hepatitis B. So that's not a contraindication to treating hepatitis C. It's just important to start treatment for hepatitis B while we start treating hepatitis C. And then during antiviral therapy for hepatitis C, it's important to have clinic visits as well as telephone contact. This is important to make sure that we answer patients' questions as well as assessing them for adherence and for any drug-drug interactions as well as adverse effects. It's important specifically at 4 weeks to assess the patient's renal function as well as hepatic function, and that determines whether we can continue therapy or not, depending on whether the regimen is renally cleared or hepatically cleared. In fact, if there is a 10-fold increase in ALT at week 4, it's actually recommended to discontinue hepatitis C regimen. And then it's important to also get the viral load at week 4. And the reason is because we want to, these regimens that we have for Hep C are very potent. So by 4 weeks, we should get significant reduction in viral load. So if we don't see a significant reduction in viral load by 4 weeks, it's either because the regimen is not working. So, that's important to detect early on so that we don't, continue a long duration of therapy, especially these agents are expensive. So it's important to assess the patient's viral load at week 4 to make sure the patient is responding. And if the patient is not, it could also be due to lack of adherence. So it's important to assess adherence if the patient is not responding by week 4, to make sure that resistance doesn't emerge during therapy. And then we need to get one last viral load 12 weeks after completion of therapy, and that's to ensure that the patient has actually been cured. So this is a visual representation of when to get the viral load. So on the vertical axis, we're looking at plasma RNA, Hep C RNA levels, and the horizontal axis, we're looking at time. So before we actually start treatment at baseline, we need to get the viral load. And then during treatment, we need to get one viral load at week 4. And then let's say if the duration of therapy was 12 weeks, at the end of treatment, we don't really need to get the viral load. In clinical trials, they did get viral loads at the end of therapy, but in clinical practice, we don't. Instead, we wait 12 weeks after the end of therapy. So 12 weeks after week 12, which was the end of therapy, would be week 24. And that's when we actually get the viral load. And if that's undetectable, that actually determines clinical cure.